Hi, everyone. My name is Kelly Cummings. I'm faculty in the Division of Geriatrics at Weill Cornell Medicine and a former Mount Sinai Geriatrics Fellow. Thank you for listening in today. I'm going to be talking about perioperative management for the older adult. I have no disclosures to discuss. By the end of this talk, I hope you all will be able to perform a perioperative assessment for older adults using both the indices that assess cardiac and pulmonary risks, as well as evaluation of several geriatric domains. And I hope you'll be able to recognize and prevent common surgical complications for older adults. As the population ages, the surgical population is also aging. This creates complexity. As patients are aging, they accumulate comorbidities, develop polypharmacy, and other geriatric syndromes such as functional or cognitive impairment. More than 20% of adults over the age of 65 have 3 or more medical conditions. So careful attention must be paid in both the preoperative and postoperative period in order to prevent and manage common complications that may arise. Several studies have shown that age itself is an independent risk factor for several postoperative complications. Firstly, pulmonary complications such as atelectasis, pneumonia, exacerbation of underlying chronic lung disease, respiratory failure, and prolonged mechanical ventilation. And pulmonary complications are predictive of increased short and long-term mortality for older adults. And they've been reported to prolong hospital stay by an average of 1 to 2 weeks as well. Another postoperative complication is delirium. It's very common in older adults undergoing major surgery, affecting up to 50%, with the highest incidence occurring after emergency, cardiac, or major orthopedic surgery. And up to 40% of older adults who develop postoperative delirium never return to their preoperative cognitive baseline. So this can have devastating effects for patients. In a large Medicare database study, the rate of readmission to the hospital within 30 days of outpatient surgery was also significantly higher for patients over the age of 80. And besides just age, underlying cognitive impairment, functional dependence, malnutrition, and frailty are all risk factors for adverse outcomes of surgery such as mortality, functional decline, and institutionalization. And so the goal of the preoperative assessment is not to clear the patient for surgery, but really to perform a comprehensive evaluation of their medical comorbidities as well as their geriatric vulnerabilities. This then allows for accurate surgical risk assessment and allows you to discuss with the patient and their caregivers whether the surgery is consistent and aligned with their goals. If the patient decides to proceed with surgery, you're able to then develop an individualized plan to optimize them prior to surgery and discuss ways to prevent and minimize risk of complications in the postoperative period. The preoperative risk assessment of a geriatric patient, it contains still all the main traditional components of a preoperative risk, such as cardiac and pulmonary risk, but it also involves the evaluation and optimization of several geriatric domains and their medical comorbidities. And so I'm going to go through step 1 is kind of the evaluation process. The preoperative assessment should begin with a discussion of the patient's overall goals and expectations for their surgery. Does the patient want surgery to help manage symptoms such as their chronic back pain? Are they looking to prolong life or for curative disease? Or are they hoping to prevent future complications? And do we think as their clinician, this surgery will accomplish their expressed goals? Want to make sure that their hopes for the surgery really match what we anticipate the expected outcome to be. Do they have a reasonable expectation of what the postoperative recovery will entail? And do they have the necessary supports and care in place to help them in the postoperative period? I recently went through this with a patient of my own who underwent a neurosurgical procedure for correction of her essential tremor. And she's a very functional woman, takes care of her elderly husband who's disabled at baseline. And while the neurosurgeon went through all the potential risks, dizziness, some element of functional impairment postoperatively, she had no idea actually how devastating it was going to be in the first few weeks of recovery. And she had to hire last minute, privately, some help to help her and her husband because she had no idea how disabled she was going to be for the first few weeks. And so really talking through this beyond just listing out potential risks, trying to picture for the patient what postoperative period might actually be like for them is really important. It helps give the clinician insight, the patient's realistic expectations, and also frame discussions around their risk. The patient should also be counseled, not just on the traditional risks, X amount of percent of heart disease or MI, but you really want to think about their geriatric vulnerabilities, their risk of delirium, their risk of institutionalization. And again, this is going to be informed by the comprehensive evaluation of geriatric syndromes. You want to counsel them on non-pharmacologic ways to prevent delirium, the importance of their perioperative and postoperative nutrition, as well as even physical therapy in the preoperative period and postoperative period. And anticipating, again, potential care needs, need for wound care or drain management or 24-hour assistance. And the preoperative period is really the ideal time to also discuss advanced care planning if the patient doesn't already have it in place. They should be counseled on the importance of selecting a healthcare proxy who could speak for them if they were unable to make medical decisions for themselves. And they should also be counseled on completing an advance directive to help their medical team understand their wishes if a serious complication were to develop. Moving on to cardiac risk. So it's estimated about 25 to 30% of postoperative deaths are from cardiac causes, and the likelihood of postoperative cardiac events are directly related to age. The cardiac risk assessment is the most fully developed and widely investigated portion of the preoperative medical assessment, and so I am going to spend a good portion of this talk going through it. And to go through the cardiac risk assessment, I want to talk about two patient cases. So patient number one is a 72-year-old female. She has a past medical history of diabetes, hypertension, hyperlipidemia. She is on metformin, lisinopril, and atorvastatin. And she's here to see her doctor today for preoperative evaluation before cataract surgery. Patient number two is a 76-year-old male. He had a history of a myocardial infarction 5 years ago. He's also had a history of a stroke 2 years ago. He has hypertension, hyperlipidemia, a AAA, and he's a former smoker. He's on aspirin, Plavix, lisinopril, atorvastatin, and metoprolol, and he's here for perioperative evaluation for a AAA repair. So going through the cardiac risk assessment, in 2014, the American College of Cardiology and the American Heart Association published an algorithm for preoperative cardiac assessment that we still use today. The guideline calls for consideration the following clinical risk factors. So starting with, is the surgery emergent or not? And if it is an emergency surgery, the algorithm says to proceed with surgery. If it's not, if it's urgent or elective and consistent with the patient's overall goals, then you move on to assessing for major cardiac risk factors, such as unstable angina, recent MI, decompensated heart failure, dyspnea, or history of moderate to severe valvular disease. If any of these are present, you want to assess and correct these conditions before considering surgery. And so you may then decide to do echocardiogram or correct an arrhythmia with medication first, address patient's dyspnea and the cause for the dyspnea. If they do not have any of these major risk factors present, then you move on to assessing the overall risk of the procedure. And so the risk of the procedure, low risk surgeries have a less than 1% risk of major adverse cardiac event. And these are surgeries such as cardiac, endoscopic, breast, dermatologic, or any sort of superficial procedure. For patients with medium risk surgeries, they have between like a 1 and 5% of major adverse cardiac risk, of having a major cardiac event, excuse me. And these are surgeries such as intra-abdominal, major orthopedic, genitourinary, or neurological procedures. And then high risk have greater than 5% risk of having a major cardiac event. And these are surgeries such as vascular, intrathoracic, transplant. Once you've assessed the procedural risk, if it is not a low-risk procedure, then you want to move on to the patient's functional status and their exercise capacity to help determine whether or not to proceed with the surgery. And so there's a few ways that you can assess this. One commonly used is their metabolic equivalence, so the evaluation of the patient's exercise capacity, with a goal of a MET greater than or equal to 4. Looking through this chart here, you can see around a MET of 4 is that they're able to do light housework, dusting, washing dishes, and you want them to be greater than or equal to that. So can they also climb a flight of stairs, walk up a hill, or walk on ground level at 4 miles per hour? Anything less than this, then you would think about whether or not the patient is medically appropriate for or would further cardiac testing change your decision about whether or not to proceed with surgery. Another way to evaluate a patient's exercise capacity is an index called the Duke Activity Status Index. And this can be a more objective measure of functional status. And an example of this can be found on MedCalc or MDCalc. And so it's a 12-item questionnaire utilizing self-reported physical work capacity to estimate a patient's metabolic equivalence. And so you can see here it goes through just like a lot of more like daily living tasks. Are they able to take care of themselves, walk indoors, do light housework, all the way up to participating in strenuous sports or doing yard work or heavy lifting. So for patients with poor or unknown functional capacity, you're going to assess utility of further quantification of cardiac risk and the patient's willingness to undergo such cardiac testing before surgery. There are several scales that can be used for further quantification of cardiac risk, and I'm going to go through those now. So one such scale is the RCRI, or Revised Cardiac Risk Index. And this looks at several patient factors, and it does include one preoperative testing that you would need to do, which is evaluation of their creatinine clearance or kidney function. And then taking into comorbidities such as heart failure, diabetes, their history of stroke or TIA, coronary artery disease, and then also what type of surgery they're undergoing. Is it a more high-risk surgery, intrathoracic, intra-abdominal? A total score greater than or equal to 2 does confer an increased risk of major adverse cardiac event. Another scale available is through the American College of Surgeons called the NSQIP Risk Prediction Tool. And this looks at both the procedural risk itself, which is really detailed because you can put in the CPT code for the specific surgery. And it also looks at several patient factors themselves, their age, gender, functional status, comorbidities, and things such as smoking status, even steroid use, BMI. I do like this tool as well because it generates estimates not only of numerous surgical outcomes, but it also includes several geriatric outcomes, their risk of developing delirium, new functional decline, new mobility aid use, and pressure ulcers. And I'll show you an example in a few slides. So going back to our cases, patient number 1, remember she is here for preoperative evaluation for her cataract surgery. So it is not an emergency surgery. So then you're looking for the presence of active major cardiac risk factors, right? So such as recent MI, chest pain, dyspnea, unexplained dyspnea. She doesn't have any of those. And so then we look at procedural risk. It is a low risk procedure, cataract surgery, and therefore no further testing is indicated and the patient can proceed to the OR. So no further laboratory testing or cardiac testing. Patient number 2 is a 76-year-old male. He has a past medical history of MI 5 years ago, right? He's always got some high-risk active cardiac risk factors, but it was 5 years ago for the MI and the CVA was 2 years ago. He's here for preoperative evaluation for the AAA repair, but it's not an emergency. But it is a elevated procedural risk. So intrathoracic, intra-abdominal, elevated risk. And so now we want to evaluate, well, what is his exercise capacity? What are his METs? And he can ambulate 50 feet with a cane before needing to rest due to fatigue. He is unable to climb a flight of stairs. So some of this could be functional, but you got to worry, is the fatigue due to cardiac reasons? So the METs are less than 4, he's unable to climb a flight of stairs. So now you want to calculate his cardiac risk and consider if further testing would impact your decision-making about whether or not to proceed with surgery. So I plugged in his information into the NSQIP online tool, and I got a list of these potential surgical outcomes, such as his risk of serious complication, pneumonia, cardiac complications, surgical site infections, UTI, venous thromboembolism, renal failure, readmission, death. And looking at this, he's average to above average on several of these. And it even gives a predicted length of stay in the hospital of 9 days. And this was plugging in the CPT code for AAA repair and several of his patient factors. And then looking at the geriatric outcomes, so it puts in his baseline. Does he use a mobility aid? Yes, he uses a cane. He lives alone at home, no history of falls, no cognitive impairment. He's not on hospice. And he's consenting himself, not a surrogate. And so looking at his risk of outcomes, still even with that, probably just mainly because of his functional impairment, the mobility aid use, he still is at an above average risk of postoperative delirium, above average risk of new mobility aid use. So maybe he comes in using a cane, but he ends up leaving the hospital using a walker. Also new or worsening pressure ulcer. So moving on to further cardiac testing. So for that patient number 2 who we're evaluating for AAA repair, right? His METs are less than 4. He's got an increased cardiac risk based on the NSQIP tool. And so we're going to think about what other testing would we want to do for him. Electrocardiogram, it's generally not indicated in patients who are asymptomatic and undergoing low-risk procedures. But for someone like him with a known history of CAD, prior stroke, it is recommended. And if there's any suggestive findings for new ischemia, QTC prolongation, or new bundle branch block, it does portend a higher risk of cardiac complication and death, and so you may want to pursue additional testing. For echocardiogram, it should be obtained in patients who have dyspnea of uncertain cause, those who have known moderate to severe valvular stenosis, or who have not had an echo within the previous year prior to surgery, or if they've had a significant change in their clinical status since their last echo. And then for non-invasive cardiac testing, whether or not this will change management, it should be considered in patients who have clinical risk factors undergoing intermediate to high risk procedures, or those with low functional capacity, such as our patient number 2. It is under pretty rare circumstances that coronary revascularization with PCI or a CABG should actually be performed before non-cardiac surgery to decrease their risk of cardiac complications, but maybe medical management would be considered. And then in terms of other further cardiac testing, there was a recent recommendation in 2023 from a guideline from the European Society of Anesthesiology and Intensive Care that looked at the use of cardiac biomarkers such as troponin or NT-proBNP or BNP. And they did not find sufficient evidence to suggest that routine evaluation of these cardiac biomarkers was helpful for risk stratification, and so they do not recommend it either in the preoperative period. So looking at whether or not for non-cardiac surgery, in patients who have undergone PCI, if it was recent, you want to think about, the emergency nature of the surgery. If it's an emergency, you may need to proceed, but if it's not, you want to think about how far out from their recent PCI are they. And for elective non-cardiac surgery, it should be delayed about 30 days after bare metal stent placement, or optimally 6 months after drug-eluting stent placement. And again, if it's elective, it should not be done within those timeframes. For urgent or emergent surgeries, if they have to be performed within those timeframes, you want to think about whether or not the patient, if they're on dual antiplatelet therapy, whether or not you require a discontinuation of such antiplatelet therapy. And so going through this, if surgery cannot be delayed beyond those timeframes of 30 days or 6 months, your decision around continuing dual antiplatelet therapy is based on the surgical risk itself. So for low-risk procedures, say for patient number 1, if she was on dual antiplatelet therapy and undergoing cataract surgery, it is actually recommended, it's safe to continue. For intermediate risk procedures, that's like the intra-abdominal, they do recommend discontinuing Plavix or Brilinta, but the patients should maintain on aspirin. And for high-risk procedures, that's intracranial, spinal, they recommend discontinuing both Plavix, Brilinta, and aspirin. And if both antiplatelet agents do need to be stopped, they recommend consider bridging and consulting cardiology for assistance with bridging. And patients would need to be admitted to the hospital in the preoperative period to undergo that. In general, there's no data that supports initiation of aspirin in the preoperative period for non-cardiac surgery patients. Next, I want to talk a little bit about anticoagulation in the preoperative period. And so for patients on anticoagulation for a variety of reasons, right? AFib, history of venous thromboembolism. If it's a low-risk procedure, such as, again, cataract surgery or dental procedure, it is safe to continue anticoagulation. For intermediate to high-risk procedures, they do recommend discontinuing anticoagulation, and then the decision on whether or not to bridge with low molecular weight heparin is based on patient risk factors for thromboembolism, and I'm going to go through those on the next slide. And in terms of which specific anticoagulation patients are on, for Coumadin, they recommend holding about 5 days before surgery. For some of our more novel oral anticoagulants like Eliquis, Xarelto, they recommend holding them about 2 to 3 days before surgery. And you can resume them usually within 12 to 24 hours after surgery, as long as there's adequate hemostasis. So whether or not your decision to bridge is based on the patient's risk of thromboembolism. And so for patients with a low thromboembolism risk, so that's if they've had no venous thromboembolism in the past 12 months, they don't have a history of AFib with prior stroke, and they don't have a mechanical aortic valve, it's not recommended to bridge. For patients with an intermediate risk, it looks at several factors and it's kind of optional, and you want to have a risk-benefit conversation with the patient themselves. And those who are at high risk for thromboembolism are those who have had a recent embolism in the last 3 months, a recent TIA or stroke within the last 3 months, those with history of rheumatic heart disease, those with AFib and a history of prior TIA or stroke, as well as several, if they have greater than or equal to 3 to 4 stroke risk factors, which are age over 75, hypertension, diabetes, or heart failure. And then also those with a mechanical mitral valve or mechanical aortic valve. It is recommended to bridge with low molecular weight heparin. Some other preoperative medication considerations: you want to ask your patients about any over-the-counter supplements they're taking, herbal agents, alpha blockers. That's a big one for patients who are on alpha blockers for BPH. You want to have them discontinue it 14 days prior to cataract surgery because it is associated with an increased risk of complication called floppy iris syndrome. You want to think about ACE inhibitors, ARBs. You may want to consider stopping on the day of surgery, but there's no real strong evidence to confirm or refute that. Beta blockers, you just want to continue their usual dosage if they're already on it. You could consider initiating it in patients who have an intermediate to high risk of MI found on stress testing. So if you do additional stress testing prior, or if they have an RCRI score of greater than 3, and you want to initiate it days to weeks before surgery. And there's pretty good evidence for that. Diuretics, you may want to consider withholding on the day of surgery to minimize their risk for intraoperative fluids or hypotension in the postoperative period. Statins, usually you can continue them if they're already on, and they do still strongly indicate prescribing statins for patients who are undergoing vascular surgery and who have also multiple cardiac risk factors. SSRIs, they may have an increased risk of bleeding with surgery, but in general, discontinuing them before is not recommended unless routine medication reviews reveals that maybe the patient no longer needs the SSRI. And then antibiotics, there are select cardiac conditions where it may be indicated for prophylaxis for patients undergoing selected dental or respiratory or musculoskeletal procedures. So now I'm going to move on to pulmonary, an evaluation of pulmonary risk. And so there are several risk factors for preoperative or postoperative pulmonary complications. The most common pulmonary complications that we worry about are atelectasis, pneumonia, prolonged mechanical ventilation, and these do occur more often in older adults than the younger group. And the impact of these complications is more costly than cardiovascular complications as well. And as I mentioned earlier, they're more predictive of short and long-term mortality, as well as prolonged hospital stay. So a comprehensive review published by the American College of Physicians in 2006 found that age is a powerful independent risk factor for postoperative pulmonary complications. Besides just age itself, there's other patient-associated major risk factors such as history of COPD, ASA class 2 or greater, which means the definition for that is the patient with mild systemic disease. So they have mild diseases with only substantive functional limitations. That these mild diseases may be that they're a current smoker or a social alcohol drinker, obesity, even well-controlled hypertension or diabetes is a mild systemic disease, and mild lung disease. Anything greater than that has an increased risk for pulmonary complications. Deficits in their activities of daily living, a history of heart failure, serum albumin less than 3.5. The the type of procedure itself. If the surgery is expected to be longer than 3 hours, there's a higher risk for pulmonary complication, as well as those high-risk surgeries such as triple A repair for our patient example number 2. And if the patient's going to undergo general anesthesia, that's also a major risk factor. And then I listed some of the minor risk factors as well that are associated. History of delirium, weight loss greater than 10%, alcohol use, cigarette use, sleep apnea. And so in 2007, the ACP published a guideline for risk assessment and perioperative management of pulmonary complications associated with non-cardiothoracic surgery. And it calls for the preoperative assessment of pulmonary risk by appraising those predictive factors that I just went through there. And based on that, whether or not to then proceed with further testing. So for whether or not a chest radiograph is recommended, it may be helpful when those patients have known cardiopulmonary disease and an age greater than 50 years old, undergoing surgery in the thoracic, upper abdominal, or AAA. So for our patient example number 2, we may want to consider a chest x-ray routine before his surgery, given that he does have known cardiopulmonary disease. Spirometry, it's not routinely recommended in the absence of any respiratory symptoms, but it may be helpful in patients with suspected COPD that's not yet diagnosed so that you can optimize them preoperatively. And it is recommended routinely for those who are undergoing lung reduction surgery. And so reducing the risk of postoperative pulmonary complications, one of the most important things to think about is postoperative lung expansion therapy. So that's use of your incentive spirometer, deep breathing exercises, chest PT, encouraging coughing, percussion vibration, even suctioning, and use of intermittent positive pressure breathing or CPAP. These are very helpful in reducing risk of pneumonia, atelectasis. For patients who have nausea or vomiting or inability to tolerate PO or symptomatic abdominal distension in the postoperative period, nasogastric tube for these patients can be helpful in reducing pulmonary complications. The use of short-acting neuromuscular blocking agents in the intraoperative period has been associated with reducing risk of postoperative pulmonary complications. And then lastly, we do recommend smoking cessation 6 to 8 weeks before surgery. Surprisingly, there's not great evidence on that, but in theory, it makes sense, and it's potentially has some benefit and a low harm of stopping. And I think that is it for pulmonary. So now we're going to move on to the evaluation of cognition. And the preoperative evaluation of cognition is essential for many reasons. Cognitive impairment is prevalent in older adults and frequently goes unrecognized. In one multi-center study of older adults, evidence of mild cognitive impairment was found in 19% of participants over the age of 75 and in 29% of adults over the age of 85. And patients with dementia are at increased risk for the following complications after surgery: acute respiratory failure, pneumonia, stroke, and delirium, as well as acute kidney failure. And so we want to assess for patients with underlying cognitive impairment so that we are aware that they're at potentially greater risk for developing these postoperative complications. And documentation of a patient's cognitive baseline in the preoperative period allows us to have a comparison for any cognitive changes that may occur postoperatively. And so we can evaluate, a quick and easy way to evaluate for cognition in the preoperative period is to do the mini-cog. And so that's our 3-item recall as well as clock draw. And so if they have, if they're unable to do any 3-item recall, you want to suspect dementia. If they're able to do 1 or 2, then you have them do the clock draw. And if the clock draw is abnormal, then you want to think of suspected dementia. if they're able to do all 3-word recall in a normal clock, no suspected dementia. Postoperative delirium is the most common postoperative complication for older adults, affecting up to 50% who have surgery. And it's an important risk factor to discuss with your patients as part of the informed consent process because of its wide-ranging adverse complications. It's associated with increased mortality, increased length of stay, as well as long-term cognitive and functional decline and institutionalization. Most episodes occur in the first 2 days postoperative. Occurrences of postoperative delirium 2 or more days after are usually due to surgical complications and or alcohol or like benzodiazepine withdrawal. So that's important to think about. Major risk factors for postoperative delirium are age over 80, dementia, recent history or unresolved delirium, major cardiac, open vascular, or major abdominal surgery, emergency surgeries, major surgical complications such as cardiogenic shock or prolonged intubation, and postoperative ICU stay greater than 2 days. Some other minor risk factors are age between the ages of 70 and 79, a history of mild cognitive impairment, a history of stroke or poor functional status, history of alcohol or sedative use, depressive symptoms, the use of general anesthesia, minor surgical complications such as infection, bleeding, or poorly controlled pain, as well as use of anticholinergic drugs. Moving on to, and I'm not going to spend too much more time on delirium just because I know there's probably other talks during this intensive board review on delirium and hospital delirium and management of delirium, but there's several programs out there. Multifactorial approach is best, and make sure that we're screening for delirium in the postoperative period and thinking about all the ways to prevent delirium. Moving on to the last few other associated conditions that are put people at high risk for postoperative complications that we want to evaluate for in the preoperative period. One being depression. And so in one retrospective analysis, a prospective cohort study of patients over the age of 66, enrolled in the health and retirement study who underwent major surgery, depression was found to be significantly associated with 1-year mortality after surgery. Another study found that depression was associated with mortality at 1 month and 12 months postoperatively, following TAVR or surgical aortic replacement. And so, preoperative delirium has been associated with potential increased risk for mortality. And so it's something that we want to think about and screen for. You can screen for it briefly using the PHQ-2, and if positive, then follow that up with the PHQ-9. And again, I'm not going to go into the full assessment and management of depression in older adults because I'm sure there's another talk on that. Malnutrition is another important aspect to think about. So poor nutritional status increases the risk of adverse outcomes after surgery. In 2018, the American Society for Enhanced Recovery and Perioperative Quality Initiative released a joint statement on nutrition screening. They recommend that screening of nutritional status before major surgery and propose the use of preoperative nutrition screen called PONS. And this is a tool that evaluates whether the patient has a BMI of less than 18, they've had weight loss of greater than 10% in the last 6 months, or reduced oral intake by greater than 50% in the last week, or preoperative serum albumin less than 3. If the answer to any of these questions is yes, the patient should undergo preoperative nutrition evaluation to determine whether or not there's ways to potentially optimize their nutritional status before surgery. Functional dependence is also associated with multiple adverse outcomes after surgery, including mortality, delirium, institutionalization. And so we should also include this in our evaluation. And you can do this by looking at a patient's ability to perform their activities of daily living and their instrumental activities of daily living. The functional assessment helps identify patients who are at risk, and then allows the clinician to then counsel these patients on a realistic post-operative trajectory for their recovery and help anticipate their discharge needs. So again, thinking about, if we think they're at risk for losing one of their ADLs, how can we help guide them on their potential care needs post-operatively and plan ahead of time? And then lastly, frailty has been consistently associated with increased risk of adverse outcomes in the postoperative period. Patients who are frail have decreased physiologic reserve to deal with stressors, and surgery is a potential stressor. And so frail patients who have increased risk of postoperative complications, functional decline, they have increased risk of length of stay, increased risk of discharge to facility. And so there's multiple frailty indices out there that can be used to screen, but generally it should be a part of the process. And so when we look at frailty syndrome, you're thinking about things such as a greater than or equal to 10-pound unintentional weight loss in the last year, decreased grip strength, maybe self-report of exhaustion, low weekly physical activity, and slow walking or gait speed. And I'm sure, again, I'm not going to go into too much detail about how to assess frailty because I'm sure there's another talk in this intensive board review. The Choosing Wisely guidelines through ABIM have a number of things that they also recommend, or I should say do not recommend in the preoperative care period. And so thinking about, they do not recommend performing of stress cardiac imaging in those patients who are undergoing a low-risk non-cardiac procedure. We've talked about that earlier here. You don't need to perform preoperative testing, routine lab work, things like that for low-risk procedures such as cataract surgery. So you don't need to get a CBC and coags and BMP before cataract surgery. Patients who don't have no history of cardiac illness and they have a good functional status, they do not require stress testing before non-cardiac thoracic surgery. And again, we went through a lot of these already, but it's a good summary. You don't need to obtain a preoperative chest x-ray in the absence of any clinical suspicion for cardiopulmonary disease. So the key points from this talk, you want to discuss with the patient their overall goals and expectations for surgery. You want to focus in on their geriatric domains in addition to the standard assessment of cardiopulmonary risk and their medical comorbidities. You want to utilize your risk assessment, specifically, again, of even their geriatric domains to help aid in your decision-making and your management in the post-operative period, coming up with an individualized care plan to prevent a lot of those post-operative surgical risks, such as delirium or functional decline. And keep in mind, age-associated risks can be minimized with proactive assessment and management. And so we're going to finish with a board review question. This is a case of a 76-year-old woman who comes to the clinic in preparation for cataract surgery scheduled in 5 days. History includes valvular AFib, mitral valve prolapse, hypertension, diabetes, and a prior stroke 2 months ago. Her kidney function is normal. She is on warfarin, and her INR is 2.2 therapeutic right now. Which of the following is the most appropriate recommendation regarding her anticoagulation? Is it A, to stop the warfarin now and bridge with low molecular weight heparin? B, stop the warfarin now, but no bridging is required? Postpone cataract surgery 1 month. Continue Coumadin before the procedure. And so the answer is D, continue warfarin before the procedure. And so for low bleeding risk procedures such as cataract surgery or dental extractions, skin procedures, anticoagulation does not need to be withheld in the preoperative period. And this comes from a systematic review of over 11 studies assessing bleeding risk associated with Coumadin. And specifically for cataract surgery, the systematic review found that the overall incidence of bleeding was only about 10%, and almost all bleeding events were self-limited and not significantly impacting the patient's vision or overall outcome. No patient had compromised visual acuity related to any bleeding event. And so I thank you all for your time. If you have any questions, please feel free to email me. I put my email up here. And thank you so much for having me.